Welcome everyone to our panel discussion on physiologic monitoring. Joining me today for this panel, we have several esteemed professionals that I think will provide some great insights into what we should be looking for when purchasing these types of technologies. I'm going to start off with Mel Oakley. Mel, if you could tell our viewers where you are, what you do there, and a little bit about your EMS background.
Thanks, Mick. My name is Mel Oakley. I'm a director of a rural agency here in West Michigan. I'm a critical care paramedic, and I run an education consulting and training company.
Great. Happy to have you here with us, Mel. Katie, a little bit about yourself.
Hey, Mick. How are you?
Good, good. Glad you're here.
Glad to be here. My name is Katie Hall, and I am a critical care paramedic. Been in EMS for maybe about 11 years now, a little over. Currently transitioned my role in hospital setting here at UT Medical Center in Knoxville as their stroke coordinator.
Excellent. Glad you're here, Katie. And Dr. Holley.
Well, hello, everyone. I'm Joe Holley. I'm EMS Medical Director for the Memphis Fire Department and several other 911 response agencies in Western Tennessee. And I'm also the State EMS Medical Director for Tennessee and a longtime researcher in the field of cardiac arrest resuscitation.
Wonderful to have you with us today, Dr. Holley. And Dr. Drennan.
Great, thanks, Mick. I'm really happy to be here today. So my name is Ian Drennan. I'm an advanced care paramedic just north of Toronto in Ontario, Canada, and a resuscitation scientist and assistant professor at the University of Toronto in the Department of Medicine.
Great. So wonderful to have all of you together in the same place so we can talk about physiologic monitoring. And I want to start the conversation off with a little bit of exploration of what physiologic monitoring that your respective organizations do, and use that as kind of a framework to get into some of the other questions. So let me start with you, Katie. In your experience working with the ambulance services here in the eastern part of Tennessee, what's been your experience beyond maybe just EKG monitoring? What other sorts of physiologic monitoring are they doing in the course of resuscitation?
We have definitely utilized the gold standard in end-tidal CO2 capnography and really kind of pushing that for, precursor to ROSC and the quality of compressions that you receive by maintaining those appropriate ranges. So that's kind of a big focus in our area.
Has there been any physiologic monitoring with any real-time feedback with accelerometers or any of those parameters being monitored?
Not as popular in this area. There may be some different services that pilot those. I've not necessarily worked with them firsthand.
Okay, very good. And how about in Michigan, Mel? How are things doing there with regard to physiologic monitoring?
Thanks, Mick. To echo Katie's comments, end-tidal CO2 is basically our bread and butter when it comes to real lifetime stuff. We'd like to see a lot more of the accelerometer and the hand placement data that comes out of that stuff. We haven't seen a lot of it lately. Kind of looking to see what we can get going with that in the future, but that seems to be the kind of the crux of what we've had access to so far is just the breath-to-breath monitoring with CO2. Yeah,
and supplementing our ECG monitoring, of course. And are there other parameters that you're looking at from your perspective, either statewide, Dr. Holley, or with any of your specific services?
Well, as has already been mentioned, end-tidal CO2 is clearly the gold standard. But I will emphasize a couple of issues related to that, and that I think we don't take advantage of like we should. And that is to say that the waveform functionality in end-tidal CO2 monitoring is probably the best way we have currently to ensure that the airway is in the right spot and stays in the right spot throughout the resuscitation. And I actually instruct all of my medics to record end-tidal CO2 waveform from the time you started up until you transferred care to the emergency department, just so that we can catch that occasional occurrence of ET tube or airway being dislodged. Beyond that, obviously the use of the numbering component of end-tidal CO2 as a director toward the quality of your CPR, the appropriate time to consider discontinuation or termination of resuscitation efforts, et cetera, is extremely important. That is probably the most important physiologic parameter I think that we monitor related to that extremely important decision. So for my crews, I don't really care about how long the resuscitation's been going on. I care about whether or not we've maximized our ability to provide perfusion and what the physiologic parameters are telling us in regards to the need or the appropriateness of either discontinuation or continued resuscitation and transport.
Indeed. And Dr. Drennan, could you comment on what you're commonly seeing people monitor up in your area, and then maybe elaborate a little bit on what things you think that people might want to consider monitoring that perhaps we haven't mentioned yet?
Yeah, great. I think as everybody else mentioned, our gold standard as well is end-tidal CO2 monitoring. It's if anyone has an advanced airway, it's a requirement that they also put on the end-tidal CO2. I agree with Dr. Holley. I really think that we have both components are extremely important to that, the number and the waveform that you're seeing. And we're starting to push that our medics use it just with our BVM ventilations as well. A little bit unsure about what the numbers mean exactly with BVM ventilations. You do get a little bit more variability with it, but I think the waveform with that is really important, and just looking to see whether or not you're getting a good waveform and air is going into the right spaces. So we push that early in the resuscitations. We push that throughout the resuscitations, and we use it for the variety of indications that the others have already mentioned. In addition to that, most of our services, if not, I'm sure somebody will correct me, but if not all of them, depending on the monitor that they're using, we do have real-time CPR feedback that they all use as well. So depending on your monitor, they'll use whatever real-time dashboards are available to them based on that monitor. And so we strongly support all of our services using that. We download that data for them afterwards to look at CPR quality, and some of our services will give individualized or service-wide feedback to our medics to say this is what your CPR is looking like when we're doing when you're running your resuscitation. So it's good for them during the resuscitation, but also as kind of a feedback tool as well. So those are kind of the standards that we'll see a lot of within our services. There are a couple services that are looking to kind of incorporate a little bit more ventilation monitoring, and we talked about that in a previous panel. But one of the things that seems to be missing a little bit is monitoring our ventilation quality, and so we're starting to see a few services look at incorporating that. I'm not sure exactly where that will go, but definitely another parameter that would be useful for people to monitor if they have the capabilities is to look at the rates and the volume of ventilations that are being delivered during the resuscitation, because I think what we learned with CPR quality is when we weren't measuring it, we weren't quite as good as we thought we were until we started measuring it. And I think we would probably find a lot the same with our ventilations, or maybe we already have a suspicion that our ventilations probably aren't as good as we think sometimes. So measuring it becomes that first step in trying to improve what we're doing.
So we've been able to measure ventilation rate through our capnography waveforms, assuming you're using capnography. And even in the absence of capnography, I remember when I was going through all of my post-cardiac arrest files in years gone by, I would be looking for that undulation of the ECG waveform to kind of infer whether or not there were ventilations taking place. But obviously the technology's evolved a little bit further than that. But Dr. Drennan, could you comment a little bit more about that ventilation volume channel? Is it using a pneumatac, or what sort of instrumentation is being used now in the field to try to measure resuscitation ventilation volume?
Yeah, so I guess more some of the newer technology uses flow sensors that you would kind of hook up similar to, on a BVM tree or an airway tree where you have your end tidal CO2, and then you could have a flow sensor that would look at measuring volumes in addition to the rates, which I think both are really important. The one piece that I think is still missing that I would love to see as well is a better way to measure the pressures that we're delivering with manual ventilations. I think even with these devices, that's a limitation that we have, I think, and a really important piece as well, because part of what we're trying not to do is use excessive ventilation pressures as well. So I think there's lots of different components to this, but the ones that we see a couple of our services use now are using flow sensors where they can measure the volume of air, and then obviously the timing of the ventilations that are being delivered. And so we'll see if that results in improvements in ventilations, at least according to guideline recommendations, and then we'll see what happens from there.
With regard to the mainstream CO2 sensor for capnography, as well as these flow sensors, in your experience, have there been issues with delicacy of the sensors or them getting gummed up when you have a grossly contaminated airway? It seems like a lot of the codes I worked were all in a bar with people that just ate 30 wings, and they were often pretty messy, and that would seem to interfere with some of these monitoring technologies.
I wasn't sure who you were throwing it out to, but I can.
Okay.
I'll take a stab, and people can jump in. I mean, for us, we try our best to not get them contaminated with the chicken wings and other stuff that's in there. But once stuff starts coming back up the tube, there is that risk where if it makes its way far enough up. So we usually have the BVM, then we put our inline filters in place, but once that filter gets saturated, things can keep coming up the tube and into the end tidal CO2 devices. So sometimes our quick solution is we'll just change them out, but once they get contaminated, we usually change them out. We usually have a spare one somewhere in the bag, and we'll change it out to get one in there that hasn't been contaminated to continue with, because sometimes they can definitely affect their readings.
Yeah, and I know in Memphis, Dr. Holley, it wouldn't be chicken wings; it would probably be barbecue. I don't know if there's any differences in viscosity factors or whatever in the contaminated airway, but in your experience, have we been successful as an industry in having good processes to right that problem, short of switching out the sensor? Is there a good method for clearing the sensors if they do become contaminated?
Well, they vary obviously depending on the sensor, and although in my experience we do occasionally experience a sensor malfunction or occlusion or something along those lines where you need to blow the line out or rinse the line out, that sort of stuff. I will throw out a note of caution, and that is in the event of your utilization of end tidal CO2 and the waveform suddenly going away and your readings being kind of screwy, the answer is the tube is out, the tube is out, the tube is out, and then maybe the sensor is bad. Do not blame the sensor first, as I've seen many folks do, and spend a lot of time trying to correct a problem that it is waving a red flag in your face to tell you to correct. Because I promise you the attorneys are aware of how to read end tidal CO2 waveforms and what they mean. So just a note of caution to be sure that while those sensors do occasionally malfunction, it is rare. And you best make sure to check all the other parameters before you ascribe that as the source of your problem.
Well, you bring up a great segue to the notion of correctly interpreting the data as we get them from these physiologic monitors. And just as we've all had to learn how to properly interpret ECGs, it's kind of a core skill of becoming a paramedic now. But how about the skill of interpreting the capnography waveform? I think most everyone is got an idea of the numbers, being in a certain range. But Mel, to what extent do you feel people are comfortable and, more importantly, competent in proper interpretation of those capnography waveforms? It's great if we have the sensor, great we have the technology, but are people properly understanding it?
I think they are. The emphasis, at least regionally, locally for us, has been that that's such a big thing to do, and it's kind of the shiny new toy that we've had for a number of years now. That it's the newest thing, if you will. So it's kind of gotten a lot of attention, at least from an educational perspective in our region. That your mileage may vary, but locally, that's been kind of the cool thing. The new whiz bang gadget, neat piece of physiology to poke just a bit of fun at my in-hospital colleagues. There's been some degree of pride to my out-of-hospital friends that we had some physiologic data they didn't have and would not use and almost refused to use. So there was a bit of the, hey, if I get good at this, I know more than some people when I'm turning this patient over. And right, wrong, or indifferent, that was still some of the good-natured, usually fun that we had with the hey, this is information we have that we kind of know about our patient that will take them some degree of time to figure out once we drop them off, and we to take it to the more responsible end, we can pass along that information and give a good clinical picture right at turnover, as opposed to thinking about how long it would take for them to ascertain that kind of a picture using different tools. And that, at least for myself, gives me quite a bit of pride. I think a lot of my colleagues feel the same way, that we can have a better picture of that. Now, all that being said, is a long way to answer your pretty simple question. That, I think, drives some of the behavior of, let me make sure I'm good at this thing. 12 leads were the thing for so long, and now it's just become part of the bare minimum competencies for paramedics now, that I think that maintaining your ability to interpret capnography readings and waveform capnography at that is the new 12 lead interpretation. And so we're pushing our paramedics to make sure you're good at reading these things and interpreting these things, and recognizing the value of the data that you're gathering from that, and being able to pass it along to your turning over your receiving facilities.
Yeah, and it's an amazing, how much information is in that waveform once you kind of start peeling the onion on all the kinds of information it provides, apart from just the end-tidal CO2. So Katie, what's been your observation in terms of, field clinicians' ability to fully utilize the information that's available in that waveform, or are they still pretty fixated on just the end-tidal CO2 numbers? Are they good reading waveforms, in your opinion?
Yes, I would say that, a lot of our providers have the opportunity to become very familiar with that in their initial training throughout medic school. And it's even introduced and explained, in the basic and advanced levels as well, of, this is something to be familiar with and have a good working knowledge of. So I think that they come out comfortable with that. And it's just such a standard, in the field, just as 12 leads has been for years, that it's a big tool that we're utilizing in some cases for patients by way of nasal cannula, and being able to monitor that for our patients, not necessarily in a resuscitation time, moment. So I think that we're kind of utilizing it and taking it a little further. And I would argue that there are some rural area in-hospital providers who that's still a very foreign concept for them. So you do bring that information in, and it's always a great tool for documentation purposes at time of transport, to have that printout of my tube was in place at this moment of transport, because we like to figure out what direction to point fingers to if there's ever a tube come into question. So that just kind of helps further support us in our practice.
Sure. And Dr. Holley, what's kind of the range that you're recommending people get into with interpreting waveform capnography? Because, there's an awful lot of potential information in there, not just obviously, the end-tidal CO2, but as we've talked about a little bit before, it gives you some indication of blood flow signals. It gives you some indication of, VQ mismatching. If they aren't in arrest when you got to them, You might see evidence of pulmonary embolism, fluid resuscitation. To what extent are people being trained in EMS to interpret all the nuances of waveform capnography?
Great question, Mick, and I don't think that we are utilizing nearly the full amount of information that's hidden in that waveform. I'll be honest with you, I'm pretty happy with, first of all, recognizing the importance of a waveform when it comes to airway management, and then some of the really basic stuff that we occasionally see if there is airway obstruction, bronchospasm, etc. And then, particularly in the resuscitation space, the information that can flow out that gives you a bit of a parameter to judge the quality of the perfusion that you're providing. So, I would say, those are the real key things to focus on early on. All the rest is really great too, but those are the things that I think we struggle with the most and where the biggest bang for the buck is right up front.
Yeah, certainly during the resuscitation itself, yes. But as Katie mentioned, we're going to be, probably seeing a lot of use in the peri-arrest period, perhaps would be the best way to characterize it. Dr. Drennan, could you comment a little bit about the use of the waveform capnography for prognostication as you're working a cardiac arrest on, whether or not you're going to terminate on scene, and how that physiologic monitoring parameter may figure into your decision-making process?
Yeah, it's another excuse me, another great point, Mick, and I think that that's one of the things that we see it used for more often than not is helping to make that decision around whether or not we should continue resuscitation or there's a potential to stop resuscitations in the field. It's been in the guidelines for a little while now that you can use that as one of the tools to help you make that decision, and I think that that's kind of how we play. That's how we use it within our services. It is a good tool. It's not the only tool. There's other things there, and if you were just to rely on it, it can probably, except for the very far extremes in terms of lows and highs, it can probably trick you the odd time. But it's a very, very good tool to help you out. So if you have a patient that you're thinking, I'm not sure that this patient's doing well. We haven't got a pulse back. We've been working for 20 or 30 minutes, and now that you look down at the end tidal and you also see that the end tidal's low, that's just another tool that we have that can help confirm that this patient's probably going to have a not so good outcome. The guideline recommendations are less than 10 after about 20 minutes of ECLS resuscitation. That's probably a fairly good indicator that you're not going to get a good outcome. What we find with a lot of our patients now, though, and I'd be interested to hear if others feel the same, but we don't have a lot of cases that meet that less than 10 threshold after 20 minutes of resuscitation in our areas now. And we think it's probably because of the CPR quality since those initial end-tidal CO2 studies came into play. The focus on high quality CPR and high performance CPR has really meant that we're seeing a lot of values that are above 10. It may be high teens or low 20s, and there's a little bit of uncertainty around exactly what to do with those, but clearly the higher the number you have, the more likely that they're going to have a better outcome. And then there's the other case where you see that rapid jump in end-tidal CO2, which is going to probably be your first indicator that you have a potential for reperfusion or a ROSC back. So we teach our medics to look for that as well. Look for the jump, continue going to your next pulse check, and then chances are pretty good at that pulse check that you're going to find there might be a pulse. So if you see that jump in end-tidal CO2 while you're doing CPR, give a good pulse check to see if they have a pulse back at your next one. So that's kind of how we look at it. The really lows and the really highs, and then we have a lot in that middle ground though that we're using as a tool, but we're not 100% sure exactly what to do with those middle ground values at this point.
Sure. And my last question is going to be more about the presentation format. We get all of this data out of these different physiologic monitoring channels, ECG, waveform capnography, compression depth, et cetera, et cetera. The way the data is presented back to us in real time, to make our interpretations on those screens. Is there anything that you would like to see different in the way that's perhaps formatted? And I'll start with you, Mel. Obviously, we're used to the standard, 25 millimeters per second speed on the ECG waveform, but I think a lot of us appreciate the value of those code summaries where it kind of squishes everything together. And when you look at those code summaries, you can see the fibrillation getting coarse and narrow, and there's just a lot of different information you see with just a difference in the way the information is formatted. Any thoughts about what we might do a bit differently to present the information back to the clinician during the heat of the resuscitation that you think might be helpful?
So one of the things I think would be good, and if I get to dream now, which it sounds like I've just gotten some license to do,
Yes.
I think it would be nice to be able to highlight a channel on my device and have that channel show up maybe larger. So if I really don't need a couple of lines of ECG if we're still in CPR or whatever for that matter. If I could just click on one and have it expand, so I could analyze it a little bit better from some distance away, as opposed to having to get right up close or even printing it off to analyze it. Those of my peers who may be watching would recognize that I'm getting older, and being able to see and analyze from closer up close. I'm glad that my peers here, at least my new friends, are laughing at these supposed to be jokes, but deadly accurate. Being able to recognize that, and also being able to snap snapshots of those things to say, I want to see this and look at it and record it in that moment. So I think about the point Katie made, which I think was great, is we record at the moment of turnover in the hospital, my capnography was running and my tube was flat out good at that moment. Being able to do a quick snapshot of those things and have it just one or two boxes, all it takes to, or breaths is really all it takes to show that we've got good access or good securement there. Where if I'm looking at it and trying to decide what's going on with this thing, being able to see it a little bit bigger from across the room during an active resuscitation might be pretty nice. Being able to switch back and forth between a big view of what my rhythm's doing and a big view of what my CO2 is doing as I'm going back and forth. So if I'm running a code from some distance away in the pre-hospital setting, we usually have whatever size screen we have, and any clinical data we're going to get is going to come across that. I've, without naming names, I've seen some devices come into market recently that are separated devices, which would allow the lead practitioner to stand farther off from where the patient access is and be able to look at data up close without having to be up close. If anything in the last year has taught us that the tethering of our equipment with a short distance, obviously almost all at less than 6 feet because this is transport medicine, that 6 feet line mattered a lot more in the last 18 months than it ever did before. And being able to bring something closer to you and be able to see it and analyze it and look at it closely also meant putting yourself a whole lot closer to where the patient was. And that maybe wasn't always the most clever way to do things. If you look at the to pontificate just a little bit further, we were sending a single crew member into the house for a little while there, and that wasn't necessarily always the advanced crew member. So if we had the ability to remotely look at a CO2 on somebody without having to be smelling distance away from the patient, those kinds of things would be pretty cool. So that'd be my dream and wish list.
Yeah. So take the dream cap, Katie, and if you could be granted a wish by the physiologic monitoring fairies, what would you ask for? Anything different?
I think that we certainly learn in this world from the very beginning, day one, you adapt and overcome, and you do the best you can with what you've got. So, and I think I would just kind of echo Mel on that, and being able to zone in on a particular feature or particular waveform and kind of make that a little larger in terms so that I can kind of better analyze it. And we're not necessarily having to print something to looks that takes us away from the real time information that we're seeing and things like that. So I definitely kind of echo that, and being able to maybe have that distance, because in a perfect world where we have more than enough hands available to perform everything simultaneously. It is really great to have, an essential lead provider to be orchestrating the chaos, at a distance, to be able to truly kind of zone in on that critical thinking skills aspect to understand what they've got in front of them.
Sure. Dr. Holley, any thoughts about what you would like to maybe see different in terms of data display or data visualizations?
Well, apart from the really great ideas we've heard so far, I think there's great value in integrating together many different parameters as an overall real-time performance indicator, as it were. Is your rate where it needs to be, and is your depth and your pauses and your ventilation rate, all of those things sort of rolled together in a single, easy to read way, so that the people that are providing those skills have a quick way to assess where they are in the big picture, and do they need to focus on some component of their resuscitation activities.
Yeah, so a performance index, if you will. All right. And Dr. Drennan, what value do you think there might be, if any, in more of a trend analysis, perhaps, was one of the thoughts I had, if you could comment on the potential utility of that. Because, it's something that I've seen available in technology, for example, on ST segment elevation, that doesn't seem to get a whole lot of traction, but from my perspective anyway, seems to be a very interesting potential there. Would you see, more of a role in any of these compressed views of any of these parameters or trend analysis?
It's a great point, Mick. That's actually the last thing I was going to bring up, because everyone else had such great ideas. I wasn't sure what else to add to the wish list, so I thought maybe I'll talk about trends. So thanks for leading me into that. I think there is value in end-tidal CO2 trends. I think we have to figure out exactly how to use them more, but uptrending or downtrending values over time tend to give us better outcomes than, or sorry, uptrending values tend to give us better outcomes than downtrending values. So being able to look at that, I think, would be valuable. I think looking at a single number, it just gives you that single snapshot in time, but having an idea of how the resuscitation going by looking at the trends of the end-tidal CO2 values over the duration that you've been performing the resuscitation, I think could be valuable. So I guess the real challenge for companies is going to be trying to fit, as we get more and more of this physiological feedback, how we fit it all on the same screen is going to be the real challenge, so that people don't get overwhelmed by the number of numbers that are out there. So I don't know if that's by like Mel was talking about, being able to zone in on specific areas, or being able to flip back and forth between screens. But if they could add in somewhere that you could easily, you wouldn't need a trend all the time, but if you could add in somewhere easily where you could pull up the trend, so if I wanted to see how, where did I start at my end-tidal CO2s again, and how have I been going, I think that would be useful, just for people to be able to have that opportunity to look at that.
Yeah, and I think that'll become true if more channels get added. Something you and I talked about in your State of the Technology presentation was the potential of cerebral oximetry monitoring. And if that starts getting some traction, that may add another channel onto the display, and further my and Mel's challenge in reading these increasingly smaller waveforms crammed onto a single display. So great information, everybody. I hope this will be helpful to all of you as EMS decision makers as you start having conversation with your suppliers about the sorts of physiological parameters that you'd like to have in your equipment. But just as importantly, a lot of information here about how to make sure that those technology investments are being appropriately leveraged, making sure that your crews are actually taking advantage of those physiologic monitoring signals, can properly interpret them, because it's all about good implementation at the end of the day. So with that said, we'll go ahead and wrap up this panel discussion, and we will then have our live Q&A in just a moment. So be thinking about some questions and comments to offer to our faculty members and panelists in the next section. Thank you very much for being here, and thanks all of you for being on the panel.